I said, my name is Dr. Alex Rabinovich. I'm an orthopedic surgeon practicing out of Canada, just outside of Toronto. I'm accompanied here by Dr. Monika Yazdanian, who is a scientist who I've known for nearly 30 years, actually. And over the years, we've established a very strong relationship, not only personally, but also from a research perspective. And I'm very pleased to be here to present our research on something that is quite revolutionary, in my opinion, something that has changed my practice, and something that I hope will change your practice. Next slide. The outline of the study, of the presentation today, is going to include a general background, what the study was aiming to achieve, the methodology of the study, the results, the discussion, and some of the conclusions. I'm going to also tell you a little bit about myself. I did my orthopedic surgery and medical training in Canada at McMaster University, where I got my medical degree in my orthopedic surgery residency. I then went to the USA in Dallas, Texas, and I did my fellowship in foot and ankle reconstructive surgery at Baylor University Medical Center in Texas, under the teaching of Dr. James Brodsky. And then once I finished my fellowship, I came back to Canada and established my regular foot and ankle practice. In Canada, there are specialties that deal with nails much more readily, like chiropodists and podiatrists, as well as foot care nurses. And the nails that I saw in my practice were usually the very severe cases. The severe cases that could not be treated by our local chiropodists and podiatrists and nurses. And by the time they got to me, they were so severe that the only option that I really had was removing the nail. Almost 10 years ago, Monika approached me, and as a scientist, she came across a very innovative treatment on treating toenail fungus using light.
I pop in for a minute and just introduce myself a little, just so there's a voice to the face on the screen. So hi everyone, I'm also very glad to be joining you tonight. So I'm the CEO and co-founder of ToeFX, Dr. Monika Yazdanian. I work on light-based therapies for nail and skin infections. Just a bit of background. It's a bit of a mix, my background. I'm a scientist by training with a PhD from Cornell University in New York in chemistry and nanoscience. I started out looking at molecules in microscopes, and I ended up now dealing with fungal infections. So a change for me, but a very welcome one. And I'm excited to be here today. So back to you, Alex.
Oh, thanks, Monika. So like I was saying, Monika approached me almost a decade ago regarding a novel treatment that I thought might complement my regular practice right now. And we started talking about it, and I advised her that probably the best way to approach this is to conduct a study. And we started thinking about it, how we're going to do it, what we wanted to achieve. And today we're going to show you our results. And this study has been accepted for publication, and will be coming out shortly once it gets edited by the journal, which has already approved it for publication. So let's dive into this presentation. Monika, next slide, please.
Sure. I would add that the study, just a big picture overview of the study, it's a 3-site real-world cohort of 101 patients, 165 great toenails. And I'd say predominantly what makes it quite interesting, and certainly Dr. Rabinovich found it interesting, was that we are focusing on the severe cases, including total dystrophy, including dermatophytomas, things that we thought it was odd are often excluded from some of the published studies in this area. So the clinical protocol used an LED photodynamic and photodisinfection system supplied by ToeFX, but there are other light-based approaches in the literature, non-thermal dual wavelength laser systems, such as something you might know, the lunula laser, and certain intense pulsed light devices for nails. So we'll give you some more education on that.
The clinical forms of onychomycosis, as most of you know, come in different varieties. We have our distal-lateral subungual types, dermatophytomas with deep longitudinal infections that are hard to reach. We got the total dystrophic nails that are the most severe forms. We got the proximal subungual, which are more rare, but often seen, at least in my practice, in my clinics. We got the superficial white, which are less severe. Next slide, please. The challenges in treating these cases is that as they become more severe, the nail gets so thick and damaged, it's very hard to reach the nail bed to treat it. And a lot of the studies that are out there are not treating the most severe cases. They're treating the mild cases that are easily reachable. So we wanted to know if photodynamic therapy with an active chemical that gets activated with the light can treat these more severe cases.
And just adding to that, it was actually, just to put some numbers to it. So in this study, in the inclusion, 93% of the nails included were severe, and plenty had matrix involvement and dermatophytomas. So we wanted to focus on things that had been resistant to other treatments. So these were the mean number of years that the patients had the infection was about 10 years. So, and 87% of them had tried something else already.
One of the things that we wanted to also identify with our protocol is we wanted to exclude ones that are not infected but look like infections. So there are nails like onychomycosis, which can be thick and curved and deformed, but have negative cultures. One of the things that ToeFX was able to provide is a very reliable PCR testing in order to identify fungal infections. And this is something that has been developed by ToeFX in order to help clinicians make the proper diagnosis. Next slide. Conditions like lichen planus can also sometimes be confused for fungal infections, and that's why we ended up taking specimens and testing all of them to make sure that we are treating fungal infections. Next slide. Autoimmune diseases like nail psoriasis can happen, can also be tricky. And if you're using an antifungal treatment on this and it's not fungus, it's not going to work. So we needed to exclude them. Next slide. Bacterial infections are often mistaken to toenail fungal infections. Sometimes there are multimicrobial species in there. And these have to be treated differently. Maybe with some oral antibiotics if it's bacterial. But one thing that we found, and we are finding, is that photodynamic therapy may actually be helpful in treating multimicrobial species, not just fungal, but even bacterial species. This is something that we're going to address maybe a little bit later, but wound care for future applications has been studied with photodynamic therapy. And we are developing a photodynamic system that can help treat multimicrobial infections, not just fungus. And as the studies here show, there are some studies on infected leg ulcers with multimicrobial infections, and there are even studies on fungal infections from 2016 showing that photodynamic therapy can be beneficial. So this is something that you should keep in your back pocket. Monika can elaborate a little bit more on that as well.
A little bit. We get excited about fungus because we spend all our time thinking about fungus and living fungus. So this 2016 paper, that was really interesting to us because it showed how prevalent fungi are in the microbiome of the wound. So we're about to present this study to you where we spent all this time looking at fungal infections and how light therapy can be so effective against fungal infections. So the idea that it can be kind of readily extended to other places where fungi like to live on the surface of the skin, it's really exciting to us. So we see that as a future direction for our R&D program.
I'd like to highlight some close-up on the severe onychomycosis, the aging, and a self-perpetuating cycle. The worse it is, the worse it gets. Next slide. Aging plays a strong role in onychomycosis, as most of our patients are elderly. And as Monika said, in our study, a significant amount of patients have had infections for a median of 10 years, an average of 10 years at all. As aging increase, we have decreased peripheral circulations to the nails, poor blood flow, the nails become thicker, it's harder to reach the nail bed, the immune system is compromised as they get older, and the nail grows slower. These infections love to linger in these environments, and they perpetuate. If they get worse, they get better, the infections. They love this environment. So the worse the infection gets, the easier it is for the infection to get to spread and to get bigger. So
I'd like to remind you a bit on that because I know you were just talking about how the worse it is, the worse it gets.
Exactly. That's a general consensus in our clinic. So as indicated here, with the immune response being compromised as we age, the blood circulation being compromised, the nail growth being slow, the infection not only extends in one nail, then can spread to other nails. And we often see this. And as we get into the treatment protocol here, we're going to tell you how we started to treat these in order to help patients out.
And just on the science side, I might add something. With severe onychomycosis, it's a loop, as Dr. Rabinovich was saying. Dermatophytes, they release keratinases. They degrade the actual architecture of the nail. So this inflammation, it just keeps getting worse. The thickness blocks penetration of any kind of therapy. And then the slow growth, it just buys the fungus time to keep reproducing itself. So the therapy really has to address load, architecture of the nail, and the time of the infection. And as Alex was saying, as the microcirculatory decline, it reduces immune surveillance as well. So all of these things come together to make a self-perpetuating cycle.
And most of you know there are many treatments out there in the market. We have the topical applications, we have the oral applications, we have laser therapy. The compliance varies from treatment to treatment. The topical applications usually have to be applied daily on the nails for over a year, for sometimes nearly up to a year. The oral treatments need to be taken regularly for months. Laser treatments have to be done often. The side effects range from very low side effects in the topical to severe side effects from the oral medication, including liver toxicity. And as our aging population, we don't want to really cause them more problems than what they have. Laser treatments can damage surrounding tissues if not done properly. The efficacy rate also varies significantly between these treatments. The most common literature on the topicals show an efficacy rate of about 20%. And just to highlight that with research, those are studies where the onychomycosis were cut mild, not severe. In the oral treatments, while the efficacy is higher, you have to balance out the side effects. And in laser studies, the laser is inconsistent because of the many different techniques used to treat onychomycosis. So with light therapy, what we're going to highlight is that it can be done easily in the clinic over a period of several weeks. There are no side effects that we were able to identify, and the efficacy rate was 73%, with more than 3 millimeters of clear nail growth. And as we will show you, this was more prevalent in the more severe cases. So we're now going to show you our study protocol and our aim, which was to evaluate the safety and efficacy of a novel light therapy for severe onychomycosis, including totally dystrophic nails. And like I mentioned earlier, we wanted to include non-model patients. So we didn't want to exclude the severe cases, and we didn't want to exclude any major comorbidities. These are things that are often excluded in studies. But what we wanted to do is real world applications. The stuff that I see in my office, the stuff that most of you see in your offices, the severe cases where you tell them, I can't do anything about it. Well, now you can.
And you'll see that there's the clinicaltrials.gov identifier there. There are other studies also on light therapy, very similar systems to ours, also seeing similar results. So study out in Brazil, study in Spain. These predate ours, but the system is similar and the results are there. We like the one where it's comparing to fluconazole. They saw significant improvement using photodynamic therapy compared to fluconazole. So some compelling results. The references are there if you need them. I'll move it along.
Next slide. So these are the type of nails that we wanted to identify in our study, as most studies excluded these nails. Our study was a longitudinal study design. It was the largest longitudinal light-based therapy to date. And I mentioned earlier, we had 101 patients with 165 gray toenails. Next slide, please.
Oh, sorry. Sorry, I'm going a bit up and down with the slides. I think we mentioned it. 90 to 93% severe at baseline with matrix involvement, dermatophytomas, or less than 2 millimeters of clear nail. That was how we were assessing or how we were defining severe cases. But any typical comorbidities, except specifically diabetes, so cardiovascular disease, psoriasis, poor circulation, these were all allowed. Diagnosis was by KOH, culture, PCR, per site capability. Dr. Rabinovich was personally presiding over the Hamilton site. I think you went through a lot of that.
But yeah, I wanted to indicate that this was a multi-center study, including Hamilton, which is where I reside, as well as Langley, British Columbia, and Windsor, Ontario. And we did it between 2020 and 2023. And unfortunately, COVID was around that time. So our data collection was somewhat slowed down because of that. But we were still able to collect a tremendous amount of data, both clinical, radio and image data, and also cultural data, culture data, and PCR data. And we followed these patients for a significant amount of time in order to get the results, to make sure that these results were consistent. And one of the things that we wanted to do is, like I mentioned, we wanted to establish the safety and the efficacy of this treatment. The pre-treatment protocol was one of the most important things of this study. And whenever you are treating toenail fungus, you know the importance of debridement. And this was taught to all the people that are actually doing the treatment. A very thorough debridement in order to thin out the nail, to allow the medicine to penetrate through the nail bed and then be activated by the light is extremely important here. And what we did is we made sure that we treated all the nails at the same time. So even though our data collection was only on the great toenail, when we treated the nails, we treated all nails at the same time because we did not want any cross-contamination. So after a very thorough debridement, the application of the methylene blue was done.
And so the careful fitting was for hypokeratosis and to reduce the dystrophic mass. We dove into the literature on this, as we do with most of our approaches to our R&D. What we thought was quite interesting is it would seem kind of obvious that debridement would increase the penetration of really any topical. But what we found interesting is debridement used as a combination therapy or in combination with even with the systemic, even with the oral. There is literature supporting that debridement increases the potency or the efficacy of the oral, of the systemic as well. But if you step back a minute, it actually makes sense because you're just reducing the fungal load. Even if there's nothing to penetrate from the external, you're just reducing the volume, the fungal load. So interesting stuff. And the debridement protocol is really important. So we provided a very comprehensive training protocol. Can we move on?
Yeah. The light therapy was red light with that range, frequency range, was applied to the dorsal surface of the foot for 12 minutes. These were bi-weekly treatments for 6 months. The LED light source was not laser and did not generate heat, which means that it was safe in our population. And as mentioned, no side effects from this type of laser.
I think it was also when people were in a heightened state of awareness about their health during COVID, everyone was checking in a lot about how they were feeling. And it was nice. This is a non-invasive treatment, no heat, no pain, no systemic side effects. So the sessions were tolerable for older polymedicated patients. And that was something that helped us to complete the study effectively with almost no dropout, actually. Maybe they were bored during COVID and didn't have other places to go. That's possible. But also the treatment was well tolerated. So no dropouts.
A very interesting outcome was seeing how to use how the use of the formulation of light sensitive dye with methylene blue visibly stains involved areas. This was actually clinically satisfying because once you stain it, you can see where the fungus is. And this allows you to do a more thorough debridement in certain areas in order to reduce the fungal load. This helps in the precision of the treatment. It also helps patients understand the process. Blue, where we're working, and non-blue is where you don't need to have work done. But at the same time, it also allowed us to track how the nail grows, and we can clearly delineate between good nail and fungal nail as the treatment progresses. So this was actually a nice little feature, and as mentioned earlier, very clinically satisfying to see a new nail grow after debridement and treatment.
And if you're curious about, oh, sorry, Alex, there's always overlap in these virtual sessions, but if you're curious about how it works, you apply this dye onto the nail. It's a dye, and so it's high uptake. It stains the entire nail. But what's very interesting is within a few days, that nail on the left, or the pink area that you see, that dye just falls away because there's nothing to hold it there. Whereas in the infected region, the dye clings to it. It has a preferential affinity for the fungal region, for the microbes. So it ends up serving as a marker of infection. Now, some patients don't like the blue, but by and large, the feedback that we got was that they prefer the blue to the yellow. They prefer the blue to the crumbling nail. And also, as Dr. Rabinovich said, it's a marker of the infection. So this was an interesting and I think unique feature of this study.
We reported no side effects, as the patients reported no side effects during the treatment protocol. They had very high tolerance to it, suitable for patients with multiple comorbidities. agnostic to the causative agent, so effective against all pathogens known to cause onychomycosis. And that's actually quite interesting, and Monika can dive into that a little bit more, because there is definitely evidence we're treating a multifungal environment.
Yes, absolutely. So one thing that's really interesting is the prevalence of mixed infections. And there's a lot of literature supporting that. We saw it firsthand because we took every nail and investigated what was sitting there. And very often it's multiple things sitting there. It's multiple fungal species. Bacteria, not so much. If bacteria is there, it's dominating the plate, but the fungal species, there might be many of them. So what's nice, something like the terbinafine, the standard drug, it's a very good drug. It's tailored for dermatophytes. So it's been tested on dermatophytes. So if you have a mixed infection, these drugs have been shown to be less effective against the non-dermatophyte infection. So what's interesting about this approach, it's not a pharma approach, it's a medical device, and it's agnostic to the causative agent. So that was interesting to us. And not every patient is a fit for the oral, so potentially this could be a non-systemic option to add to the toolbox. Go on.
Next slide. This is how we measured the evolution of the clear nail. The nails were photographed on a standard piece of graph paper, so we can use proper measuring tools. Custom software was developed in order to measure nail growth, and Monika had an IT team and scientists develop that, so we can actually measure nail growth from the root further up. Monika, if you can elaborate on the software and the technique here.
Sure, that was we really wanted to be able to standardize the growth. I mean, we all know that with these fungal papers and fungal studies, sometimes it's hard to choose the endpoint because mycology in a way is nice and clean. We can measure things. It all comes out in a nice test. But sometimes it's not what the patient is very interested in. If you can show 2 successive negative cultures, it's not always a correlation with clinical reality. What we wanted to do, we chose an endpoint of clear nail growth, millimeters of clear nail, primarily because that's what the FDA tells us to do. So the FDA tells us to measure millimeters of clear nail from the most proximal end. That makes sense from sort of a patient satisfaction perspective, and it's also what other studies do. For example, we already mentioned a product called the Lunula laser. We essentially replicated that protocol just so we could compare it head by head. So custom software finds the most proximal edge, and then we're looking for how much clarity is coming up as the new nail grows in. I think we touch on that here in the success criteria.
Exactly. So one of the things that we looked at success is more than 3 millimeters of clear nail or total clearance. The secondary success rate was the negative cultures and PCR testing, at least 2 consecutive negative cultures to identify clearance. So we tracked all of these within the test population, and our results was quite impressive.
Yeah, so we looked at those. We also tracked, just because we're sticklers and we love collecting data, we also tracked 6 millimeters of clear nail as well, just for fun, and that result was nice as well. I'll pop up again for 1 minute. You'll see the graph paper in the back. That also facilitated the measurement and made it quite accurate. So every patient had a photo taken of the same piece of graph paper, just to preserve the objectivity. A bit of the technical stuff, the paired t-tests used to compare growth before and after, and the success goal, again, it was from other literature, 50% of treated nails showing the clear growth over 3 millimeters. That was our success criterion.
So one of the things that I wanted to highlight here is the success. So as we said, from baseline to 6 months to 12 months, we followed them for an entire year. At 6 months, out of 165 nails, 73% of nails achieved more than 3 millimeters of new clear nail or total clearance. And remember what we said earlier is that the vast majority of these nails were the severe cases. And you just don't see these types of results in the literature. In the severe cases, they don't have such high success rates for clear nail growth. And 53% had even more. It had more than 6 millimeters of nail growth. The mean growth overall was around 5.9 millimeters overall. And in the total dystrophic subset, the mean growth was actually 6.6 millimeters. Even encouraging given how hostile these fungal species are. And we were not cherry picking here. These are were the more severe cases, the more comorbidity cases, and yet the success rate was extremely good. And you can see how the success rate continued over to 12 months as well. So there is a very noticeable improvement that you're just not seeing in any other treatment protocol out there.
I should note how the protocol changed between 6 and 12 months. Between 0 and 6 months, these patients came in every 2 weeks. Treatment lasted about 20 to 30 minutes. They came in over 6 months, roughly 10 to 12 times. So that was quite regular. They were there was a strong and very well-preserved cadence there. It's quite important because we're tracking the cycle of growth of the fungal species. The 12 months results are a bit different. So that's not every 2 weeks. That was stretched out to more of a maintenance regimen. That's every 6 to 8 weeks. It was somewhat less regimented, somewhat less strictly enforced. That was just to see, can we maintain? Because it's always a concern. You see these nice results, can we maintain them? Can we make sure that there's a prevention of the recurrence or relapse of this infection? So the first 6 months, that's the standard, bulk standard FDA protocol. Look at clear nail growth after 6 months. The 12 months was us just going a little bit of a step further, saying, okay, can we maintain this progress, but with less frequent, less intrusive treatments?
Perfect, thank you. This is a little bit of a busy slide, but we're going to highlight some of these findings for you here. So that 73% success rate is in the second row for the total severe cases, as you can see. But the numbers, if you look at the first row, any new growth in total nails was around 86%. And for the severe cases, were around 85%. And the mild and moderate cases did extremely well. And as you can see, the more severe cases did amazingly. More than 6 millimeters of growth also did quite well, as mentioned earlier. There were a few that had no change, though. So not all nails do perfect, and some nails didn't improve. And that could be maybe relating to the debridement technique or patient factors.
Yes, and I think it's interesting. We wanted to separate out the different kinds of severity. So we did find that where the dermatophytomas were present, perhaps because of the depth of the infection, some of the results for new growth, they were a little bit lower. I think it would be a topic for a further R&D, which is what would be lovely is, can we predict in advance the patient's response to this treatment? Because obviously you're starting a patient on a course, you want them to see success as fast as possible. We didn't include it in the paper, but we did see that you could predict after 4 or 5 treatments if they were going to be a good responder to this therapy, and that's kind of pleasing as well because you're not keeping the patient on a therapy forever and ever. We can talk. There's some pictures.
So now this is, I think, a lot of whenever I go to conferences and I look at outcome studies, I always like to see either x-rays or data or pictures, because pictures always tell a very lovely story here. So we have before and after pictures of all of these individual cases. And, Monika can highlight some of them. She has the pointer there, but she can highlight some of them, some of the very interesting ones. Let's say the third one, the third one on the left, third one down.
Okay.
Um,
Oh, yes.
that one, for example, that's a nice case. We have a severe deformity here that was debrided, cleaned, and applied the treatment over several months with methylene blue and photodynamic light. And then you can see how beautiful the nail has recovered with new nail growth there. The residual dye eventually washes off and fades away as the new nail grows and pushes out the dead fungal species out of it. And eventually they get a nice clear nail. Let's say in the middle column, the bottom photo there, you can see how the nail started off with some lesions in the distal aspect of the nail, and then over treatment, all of those completely disappeared with the methylene blue and photodynamic treatment. And I'll just let you guys peruse all of them, but this is the typical results that we're getting. These some of these more severe cases after significant debridement and light therapy with methylene blue, you're starting to see these wonderful nail results. And from a clinical perspective, we look at patient outcomes. We ask them, how do you feel? How do you feel about your nails? Are you embarrassed or not embarrassed? Would you recommend this? And the results were overwhelmingly positive. Not only patients felt better, they were happier. They wanted to show their nails. They wanted to display it. They were not afraid to wear sandals and go outside and display it. So that was really impressive. And we had a lot of very good video testimonials that they provided to us because they've tried other treatments in the past and they were not successful. And now finally we have these treatments for the severe, moderate to severe cases, and even the light cases as well. But this is quite impressive. And from a clinical perspective, I see these patients in my clinic, and they're just totally happy and satisfied with these outcomes.
That was a pleasing aspect of this study. It was nice to see the patients that were happy. Some of them, I remember all kinds of anecdotes that I heard of, one of which was, I just remember this phrase, my husband hasn't seen my feet in 5 years, which was, I don't know how you achieve that, but anyway, we were able to help her unveil her feet. So a brief note just on the effect of the formulation. So it's marking out the area of fungus. This has the extra effect of being able to guide debridement, and the debridement really is important to the success of the protocol. I think that's a key thing to note. So it guides the debridement. There's also the effect of the light is to generate the reactive oxygen species just from the ambient oxygen. So that will disrupt the fungal walls and selectively eliminate the fungus. So that's what we're seeing here. We also have some data on mycological cure.
So one of the things that we did, as you know, we tested out all of these nails for any fungal species and after treatments, and the available data showed us that 59% achieve mycological cure, and the numbers there are below. And this is actually quite important to understand because some of these other treatments can also achieve mycological cure, but are a little bit more invasive and have more side effects. While this treatment has significantly less side effects, actually has no side effects, and can achieve similar or higher mycological cure over time. And this is what patients really liked as well. And this is something that as a clinician, we really like to tell patients that this can do for you as well.
And we could go back up to the table where we're showing mycological cure across the different cohorts and also comparing the mycological cure in the light therapy to the systemic, to the topical, and you'll find it's quite comparable, the mycological cure. And how did we define it? It was either negative KOH, negative culture, or 2 successive negative cultures. So some of these patients were lost to follow-up. Most of them we attempted to get at the 12-month mark. So mycology can be messy, as we all know, sampling error, intermittent lab access, different lab methods. Still, for a cohort this severe, the clinical gains plus the mycological conversion, I think it's meaningful. We can go on.
And again, we wanted to compare to other similar studies with similar treatments. So a study of patients with mild to moderate onychomycosis only, no dermatophytomas or matrix involvement treated with topical drugs like Jublia reported a mycological cure of about 53% to 55%, while ours was similar. And similar, terbinafine shows the highest mycological cure, but also has the highest complication rates. So we report an overall mycological cure of about 58%. 89% of patients were assessed as severe to extremely severe cases, which all of those other studies and companies don't even include in their studies because they're just too severe to treat. So again, we're just trying to highlight the benefit of this treatment in the more severe cases for you. Feel free to add anything, Monika.
Sure. I think you've said it with the takeaway. It's visible clinical improvement, but without the systemic risk. So I think there's a practical room for this treatment where the orals aren't ideal as a standalone treatment or as an adjunct to improve the plate environment. We compared to other studies, they showed good results. The SUSA study actually showed better results, reporting 90% clinical cure, but these studies excluded the severest cases. So you're not strictly comparing apples to apples, but it's instructive and useful to look at it nonetheless. So SUSA, that was 80 patients with 40 receiving the photodynamic therapy and 40 receiving the fluconazole. So also worth checking out. It's just, I think, nice to have this battery of supporting evidence for this emerging technology.
Thank you, Monika.
All right.
So what are the next steps? Well, we talked about combination therapies, maybe the next frontier in onychomycosis treatment.
And we touched on this a bit, which is the debridement. As someone who's a non-clinician, I didn't even really think of debridement as a combination therapy, but I mean, there's no reason, I guess, not to think of it that way. It's really important. It drives outcomes. It's been shown in just so many studies. So it was thin. These nails were thinned out to a comfortable, but I mean, you remove the dystrophic bulk of the nail. It also opens channels for the formulation. And again, it's part of this trend toward combination therapy. The bi-weekly cadence, touched on that a bit, it sustains the momentum. One thing that was nice, the clinicians were quite happy because the control of this therapy was in the hands of the clinician. You weren't really relying on the patients for compliance. So the bi-weekly seemed just about manageable, comfortable for the patients. Stretching it to monthly definitely will slow the visible gains. Alex, do you want to add anything?
Yeah. One of the other things that in my practice we speak about a lot is foot hygiene. We want to make sure that the foot is clean because, as we know, fungus spreads from toe to toe. So it's important not only to take care of your clothing, what you put on your feet, but also your foot themselves. Make sure they're dry. Make sure that you sterilize your shoes and your socks. You want to discourage barefoot walking in public areas. So foot hygiene is very important. Washing them, cleaning them, keeping them dry. Adjuncts could be topicals. One of the things that we were debating is that after doing a treatment like this, you've treated it, you've removed it, now it's clean. Can the use of adjunct topical therapies be beneficial in order to maintain this? So this is something that requires a little bit more research, but something that we're thinking about. There is expectation settings. These nails, somehow the patient got infected initially. So if you're not gonna get rid of the source of the infection, be it from the outside, then it is possible for recurrence to happen. So we always do expectation settings and goal settings and foot hygiene and environment hygiene management. So this is something that requires a little bit of care, and with the proper education of the physicians, the nurses taking care of these patients, as well as compliance with the patients, then I believe that we can manage these infections in the long term and improve nail health and quality of life, both physically and mentally, for these patients. More research, of course, has to be done on all of these adjuncts, but we feel very strong that we're on the right track with this initial treatment and our approaches on this matter.
I think about topicals as well. One thing that's interesting, it's not a pharmacological intervention. This is not a drug. So there's really no issue with intervention, with drug interaction. I know that's always a concern. A lot of these patients are older. There's a risk. They're worried about taking too many pills. So we do see the clinicians that are using this right now, they don't seem to hesitate at all to combine with other treatments. Some of these infections, everyone knows they're so stubborn that you hit them with anything that you've got. So we are happy to be part of introducing another weapon in the arsenal as one fights this infection. I always find it really interesting when we do the science. If you take a clipping of the nail and you put it in a dark black envelope and you shove it in a corner and forget about it, you can still culture that, get a live culture 2 weeks later. That is remarkable to me because you couldn't do it with a human being, right? It's these nails, these infections are very, very, very stubborn, very prevalent. Knocking them out requires a lot of persistence because they're just so resilient. So that's my addition to the topic on adjuncts and combination therapies. Some other next steps.
Yeah, we touched a little bit about this earlier, and there is some growing literature in wound care. And one of my specialties is wound care management in foot and ankle. As you guys know, foot and ankle, especially diabetic patients, can develop infections, and we're finding that in addition to debridement, in addition to proper dressings, there is definitely a role in photodynamic therapy and application of these methylene blue on top of wounds and applying the photodynamic therapy for multimicrobial disinfection. And there is definitely literature out there showing that it's possible, that is being used. And we even have now some growing evidence, and we're going to be developing a protocol in order to establish this as a adjunct to regular wound care. And I think that's really promising, is that now we're utilizing all our science and all our tools in order to help patients improve without having to resort to very invasive surgical procedures for these types of diagnoses. So there's definitely more to come, and we just want to put this little bug in your ear so you stay tuned as this will develop over the next little while.
Yeah, we are excited about that next frontier in the R&D, absolutely. But we should sort of wind it up by mentioning limitations on the study. So some limitations: cohort design. It was not a randomized comparative trial. That would be a future direction. There could be site variability in the labs, in the follow-up, and even in the quality of the debridement. That's something that, to be honest, is a little bit hard to quantify, but I can see how it would lead to some variability. So severe skew is possible. It's harder to generalize to some of the milder cases. We may be skewing for severe cases. And the mycological data at 12 months, it's available for some, but not all of the samples that we took. So always areas to improve, and those are some of the limitations on the study. Oh, I'm sorry, Alex, I should have shown this when you were talking about the potential for wound, some of the emerging evidence. I don't know if you want to comment as the wound expert on some of these photos.
Yeah, these are typical cases we see in our practice, and I'm quite impressed in how we are developing a new protocol to treat these wounds with photodynamic and methylene blue. So we are collecting more data, so stay tuned as we continue to develop this venture of ours.
Diabetes, another excellent frontier, but I'm wondering if we're at the mark where we should start turning it over for questions. So perhaps if we all agree, I'll leave it there, and we'll thank everybody for listening. We'll thank CME. Thanks to our clinical teams at all the sites, and all the patients who stuck by these protocols. And thank you for lending your evening to us.
Perfect. Thank you, everybody.
Okay, currently we do not have any questions, so I would encourage you in the audience, if you have any questions for our speakers, please type your question in the question box. You'll see at the very top of your GoToWebinar control panel at the right, there's a square with a question mark in it. That would be your question icon. Just click on that.
And while you think of questions, we can certainly chat a bit more. We have lots and lots of things to say on this. I might ask, Alex, what are your feelings about treating diabetics or neuropathy? Is that something you see in your practice?
Yeah, we obviously see quite a bit of diabetics with neuropathy as well. And it is very scary to treat patients with diabetic neuropathy because they have a higher risk of getting infections, a higher risk of complications. The duration of treatment is much longer just for general wound care and nail care. So being less invasive and more effective is the best treatment approach here. So these types of treatments I find very, very good. It's always a little bit scary to go and operate on them because I'm concerned about developing complications. But if I can avoid these procedures and try to treat them with a few months of nail care and photodynamic therapy, then I feel very successful that I've done the best I could for them. So that's definitely something. And again, like wound care is going to be a big issue here as we open our wound care clinic shortly for advanced wound care. Diabetic patients are going to be a primary target here in order to help them manage the foot complications that they generally present with. So I think this is a very impressive technology. I'm not sure, Monika, do you think you want to tell people the actual science and how this actually works? I remember when I was reading it in the beginning, that always kind of, as a scientist, I wanted to know, how does this actually kill the fungus?
Sure. I'll give a juncture in case some questions have come in. Barbara?
Yes, we have quite a few questions now.
Okay.
Okay, this is a question. Were the pictures of the ulcer, it says, were those pictures ulcers or just calluses? The last pictures you put up.
So these particular pictures are of calluses that have formed over ulcers. So once the callus was debrided, removed, the ulcer was debrided, and then the light treatment was applied with the methylene blue.
Okay, next question. Tell us about the red light generator.
Sure, I think that's up my alley. So that's it's an LED, fairly standard LED. It's a wavelength around 660 nanometers, and the strength of it, I want to make sure we quote the right number. We quote it in, here we are. 630 to 670 nanometers. It's an LED, so it's got a little peak sitting at 660 in the middle and tapering off toward those higher wavelengths. So a bit of a broader spectrum red light, which we like. It's tailored to the photoreactivity of the formulation that we apply. And it's at about 0.042 watts per square centimeter. So hopefully that answers the question. That's the profile of the red light.
Thank you.
Maybe this can lead into how this actually kills the fungus.
Oh, sure. So we apply this formulation. It's a very specific, this formulation really likes to cling to the fungus. So it binds onto it. And then when you apply the light, it starts a light reaction. So it's a dye. So the dye is photosensitive. That means it's interacting with the light. You hit it with the light, generates an excited state. The excited state generates electrons that then react with oxygen in the air. And so those reactive oxygen species, they go crazy and they start to attack the fungus. They preferentially attack the fungal organism, destroy the cell wall, and can lead to lysing of the cell. So that's the mechanism in a nutshell.
More questions.
Excellent.
Were there any cases with fungal nail and surrounding skin fungal infections? Also, can the surrounding skin be treated as well?
That is a very interesting question. So just again, I'm always giving the science perspective. That is the same organism. The athlete's foot, which we often see, so tinea pedis, it's often concurrent with onychomycosis. It's the same organism. It's dermatophytes sitting on the skin. And we do see that clinicians use it for that. So it wasn't specifically tested in this study, but clinicians will paint the formulation onto the surrounding skin, hit it with the same light, and they report to us that they like the results that we're seeing, that they're seeing there. So there is certainly no reason, just from a purely scientific perspective, why it shouldn't work. It's the same organism, sitting in the same area, and we're hitting it with the same stuff. Hopefully that answers the question.
Okay, how do you apply the methylene blue?
I think there's a ToeFX rep who will be showing that right after I speak. So that might be useful, but I'm certainly happy to explain it. There's a single-use applicator, always single-use, so you're not reusing it and risking contamination. You twist it, and it's a brush at the end, and then you brush it, you paint it onto the nail, almost like you're painting the nail. So, and that's done to avoid mess. This dye will dye absolutely everything. So this is a way, it's a nod to the clinic to keep the clinic clean. Don't drip this stuff everywhere. It's hard to clean up. But when you do it this way, it twists out. Just a drop sits at the end of the brush. You put it on the nail. But again, someone from ToeFX would be demonstrating this right after.
Next question. How deep does the light penetrate the nail? Is it deep enough to reach the live organisms?
That's an excellent question. So the whole point of the debridement regimen, the reason that we really stress this as part of the regimen is to thin out the nail. It's completely a true statement that the light has essentially maybe a millimeter or so that it's able to penetrate down, maybe a little bit more if you're lucky at this wavelength. So it is important. If you've got a nail sitting down with millimeters of thickness, I never believe it. If someone says that a laser is going to penetrate, maybe, but I don't think so. There's just too much thickness to get through. So I think it's quite important to thin down the nail. And if you do that, the light should be able to reach the nail bed, which is usually the locus of the infection. So important question. That we all know the nail itself is dead. There's no live tissue there. It's really important to get to where the fungus is actually thriving, which is typically the nail bed.
What if treatment was done every week?
Great question. We have not tested that in a clinical setting, but certainly clinicians are smart. They're medical professionals. They tweak the protocol to what they feel works for their patients. There's no harm because it's not metabolized by the body. Certainly clinicians have done that. I couldn't comment in a systematic scientific way on what the result is. Sorry.